We're going to go ahead and begin the webinar. Hello, my name is Mary Miller, Global Manager of Clinical Education and KOL Engagement. We want to thank you for joining today for our webinar, Neuromuscular Ultrasound Diagnostic Billing Perspectives by Dr. Joshua Smith. Before we begin, I want to touch on several housekeeping items. Your feedback is genuinely important to us. Please watch your inbox over the next several days for an email from Cadwell Education that includes a post-webinar survey link. Today's webinar will include a live Q&A with Dr. Smith at the end of the presentation. Please submit your questions in the Q&A box at any time. We will be monitoring them throughout the session, and we will address as many questions as we can during the live Q&A. Now, it is my pleasure to introduce today's speaker, Dr. Joshua Smith. He serves as an assistant professor of neurology at the University of Pittsburgh. He cares for patients with a wide range of neuromuscular conditions, including autoimmune, genetic, and degenerative disorders. In the electrodiagnostic laboratory, he performs nerve conduction studies, electromyography, and neuromuscular ultrasound to support accurate diagnosis and treatment. As director of the autonomic laboratory, he leads efforts to provide specialized autonomic testing for the region. He is deeply committed to quality care, advancing the field through compassionate practice. Dr. Smith also has a strong passion for medical education, mentoring medical students, residents, and fellows. Thank you, Dr. Smith, for sharing your insights with us today. And we would love to have you go ahead and begin your presentation.
All right. Well, thank you very much for the invitation, Mary. I appreciate it, and I love kind of any opportunity to provide some expertise or teaching to try to get more physicians and practitioners involved in this kind of growing field. So again, the title of this topic today is Neuromuscular Ultrasound Diagnostic and Billing Perspectives. Again, I'm Dr. Joshua Smith. Just a few disclosures. The ultrasound images that I'm going to be providing in some examples at the end are from the Cadwell Summit machine, and then I was provided an honorarium for this lecture and topic today. You know, the basic goals of this discussion are going to be understand the basics of incorporation of neuromuscular ultrasound into your practice, or specifically your EMG laboratory, and then understand some of the basics of what's required for documentation and how you can bill for neuromuscular ultrasound that you're performing. You know, one of the questions is, well, what is neuromuscular ultrasound? Just to kind of touch on the topic, you know, this is the use of an ultrasound machine to assess neuromuscular anatomic structures. So this is peripheral nerves, muscles, and related structures. This is different than musculoskeletal ultrasound, which is going to be more focused on joints and tendons. And depending on where you practice, you know, even your colleagues sometimes in radiology or bigger ultrasound labs, if you order a neuromuscular ultrasound and you say, you know, I want you to track the ulnar nerve throughout its neuroanatomical course and provide cross-sectional area values, they might not have training or expertise to do that. So this is different than ordering just a joint or a limb ultrasound. And you say, well, who should be performing neuromuscular ultrasound? And in my opinion, it should be those practicing neuromuscular or electrodiagnostic medicine. Neuromuscular ultrasound a lot of times is kind of like a point of care ultrasound, which is kind of a growing field in medicine. You know, ultrasound is not just in the radiology labs now, especially you look at like emergency medicine, even family medicine, having point of care ultrasounds. Even some universities like Temple provide those butterfly ultrasound to their graduating classes. So being able to have this kind of non-invasive testing is growing. You know, the advantage of the neuromuscular practitioner doing this is that you already kind of know the area you're looking for and what kind of things you're looking for. You already understand the pathology. You're just adding some kind of anatomical information and expertise. There is a AANEM position statement. I put a link into the talk so you can kind of look at that as well for some specific kind of qualifications regarding neuromuscular ultrasound as well. And now there is certification for neuromuscular ultrasound in particular. This actually comes from the American Board of Electrodiagnostic Medicine, so the ABEM, if you're familiar through the AANEM. And if you get ABEM boarded, so the American Board of Electrodiagnostic Medicine, you can actually add on a neuromuscular ultrasound certificate of added qualification. And you might say, do you need this to perform neuromuscular ultrasound? You do not need this, but it can be helpful if you run into issues with billing, or maybe you work at a large institution and they want some kind of reason that you should be performing ultrasound in particular, especially if you're like, well, we're working in the EMG lab and they're wondering what's the placement of that, worried about revenue changes. This is a nice thing to have. Um, Really what it comes down to is that you're certified by ABEM, and then you actually have to perform 150 ultrasounds of like nerve or muscle. And this is outside of procedure, so it's not, you can't count if you do like, oh, I did a carpal tunnel injection. Now, if you did neuromuscular ultrasound on the median nerve and then you added a carpal tunnel injection, you could do that, but it's not like procedural based or using it for guidance for needle. These are diagnostic ultrasound. And then you say, well, what do I need to do this? You need a patient, you need a practitioner who knows what they're doing, and you need an ultrasound machine. So probe, computer, and display. So if you look at what you need to perform EMG nerve conduction study, it gets a little more complicated. There's a lot more parts. Ultrasound really, the hardest thing to get is probably the ultrasound machine. But once you have that and some gel, you're good to go. Um, Patients tolerate it very well, and it provides a lot of really good information for your care. You might say, okay, so I have my patients already in our EMG lab or in the clinical setting. What kind of ultrasound machine do I need? Because there are a lot of options out there. Okay. In general, if you have a machine that can run a linear transducer, and most transducers now have ranges of frequencies on them, they're not a set frequency, ranges between 4 and 16, 6 and 14 megahertz. That's going to get you like 95% of what you really need to do, especially if you're starting done. It is really nice if it has Doppler capabilities. Most ultrasounds machines in that range, you're talking like $25,000 to $30,000. So they're expensive. You can have standalone machines, like these are some examples. A lot of EMG companies like Cadwell and Natus also have ultrasound that's either integrated into the machine or almost like a tablet form, and those work too. And you might say, how do you pick which one? It's going to be a little lab dependent. The advantage of the integrated machinery is that it's right on your EMG machine. So you did the nerve conduction studies, you did the EMG, you just kind of click a button, you grab the probe, and you can start doing the study. And it also saves everything in one spot for you. The advantages of standalone machines is a lot of times you can get them pretty fancy and add a lot of features. If you want, you can get ultrasound machines that are well more than $100,000. But when you're talking neuromuscular ultrasound, do you really need that for clinical care? No, you can get by with the lower grade machines. I would recommend you get one that has Doppler capabilities. Even the integrated machines have that now. And the technology is only advancing, probes only getting better. It's going to probably look different in 5 to 10 years again. Um, so you kind of work with your lab. I work with both settings. So I kind of have an outreach clinic where I have an integrated ultrasound into the machine because I'm the only one who uses it. But then in our larger lab down at kind of the university setting at Presbyterian Hospital, we have a standalone because we have 6 different rooms, and the standalone can kind of like move around based on who's using it, whether it's me, PM&R, one of the other neuromuscular doctors. So you can have one machine that's a little mobile. So it'll depend on your lab, but there's advantages to both, and both of them will be useful and get you the information you need to take care of your patients. And what about saving your images? So you need to save your images, just like radiology needs to save their images. Machines will save them locally, but you do need longer term storage. If you don't have something like that already in place for your EMG lab, I recommend reaching out to radiology at your institution. A lot of times they're going to just set stuff up in the computer in a cloud, and you're going to have to just eventually kind of dump the hard drive in and move it over to that. But you need that to be set in place, and it needs to be secure. So again, I rely on people that already do it. Your radiology colleagues already do this, and they already have a lot of expertise, and there's probably a lot of infrastructure all set up. Just tap into it. You say, when can I perform a neuromuscular ultrasound? This can be done as a standalone study. So sometimes I will see patients in clinic and I'm a little curious and I'll just kind of grab the ultrasound probe if I'm in the same room as my machine. When do I do it most is I use it most as an adjunct to EMG and nerve conduction study. So usually they've already had the nerve conduction study and EMG done, and I'm looking to add a little more information, a little more expertise to help me better care for them. And then I will just grab the probe and do it the same day, same time. They get kind of three tests all at one time. You might be like, well, that's a lot. But by the time they've had nerve conduction and EMG, an ultrasound is easy. It's cool gel and pictures. Usually it's a little interactive and patients like it. Um, so you will have to work a little bit with your institution to figure that out. I'm a little biased and I like it as an adjunct. But it can be done as standalone. You could set up kind of times in your lab where people just come for neuromuscular ultrasound after a study if you can't incorporate it at the same time because you're busy, or even have it as part of your clinic availability as well, depending on where your clinic and lab lie. So documentation, you can generate independent reports. So if you haven't done nerve conduction EMG, that is perfectly fine to do. It's going to kind of be a similar setup to your EMG and nerve conduction study reports regarding the demographics information, and we'll go through that. Or it can be included into the EMG report. So when I'm at the larger lab and I'm using the standalone machine, I'm not doing a whole EMG nerve conduction study report and then a separate ultrasound report. I will put the kind of technical interpretation and summary and then interpretation into the EMG report as one. And you can do that and still bill for it. I did include a link to some kind of position statements on that as well, just if you want to do some more kind of reading. But again, we're going to cover a little more like, well, how much information do I have to put in? What has to be in a summary and interpretation in order to be safe when it comes to billing? So again, NEMUS is short for neuromuscular ultrasound, but these are just some of the basics. So, it's not a surprise, same as EMG, demographics, name, date of birth, age, weight, height, gender, medical record numbers, and referring physician. And then, reason for referral, a brief description of relevant symptoms, and a brief examination depending on your lab. So this is the same thing as the EMG nerve conduction study. So if you're doing it at the same time, you've already done this. Um, some people might say, well, people come in and they have an order for an EMG and a nerve conduction study and not an order for an ultrasound. So if I do EMG and nerve conduction study and then I add ultrasound, am I able to bill for that? It does depend a little bit on the state where you work. Um, I really haven't had trouble with that in the state of Pennsylvania where I work. Um, Honestly, the cost and how much is billed for the ultrasound is very minuscule compared to the EMG nerve conduction study. One workaround is if you have like orders that your physicians send to you, or you have a centralized ordering system, is to include in your EMG and nerve conduction study order, you can have a little box that says addition of neuromuscular ultrasound at discretion of testing physician, and then leave it always checked and they can just uncheck it if they don't want that. I don't know what doctor would not want that information if you think you need it. But that's something you could have in your orders that come from the physicians that maybe make that a little easier. So let's go I'm going to divide it into kind of neuromuscular ultrasound reports for peripheral nerves and then for the muscles. So we'll kind of go through both and then we'll also go through some examples. So when it comes to the neuromuscular ultrasound reports for peripheral nerves, you need side in the nerve that you examined, description of patient positioning, the region image and plane of imaging, and then probably some of the most important information you're going to discuss is the measurement of the cross-sectional areas in the sagittal planes of the nerves, because there's a lot of normative data on that, and you're going to use that to know if there's enlargement or not. And then abnormalities in nerve signal, which you can call echogenicity, or some people call echo density. It's whatever you like to do, however you're trained. And then any abnormalities intrinsic or closely related to the nerves. And then there's more information you can provide. You could provide information on nerve mobility. If you put Doppler on, you could talk about vascularity, the ultrasonographic Tinel sign, where you're just kind of pushing with the probe and they're saying, oh yeah, that's reproducing my symptoms. You don't have to include a lot of information about further extrinsic structures like bones and other normal blood vessels, etc., you can, if you're confident in that and you have training in that, that will change your billing a little bit. But you can perform what's called a limited limb neuromuscular ultrasound. And now there is a specific code for what's called like a comprehensive neuromuscular ultrasound of the nerve throughout its neuroanatomical course. But you can do a limited ultrasound and just really be talking about the nerve or what is touching it or not touching it. And you don't have to talk about everything you're seeing on the screen. Um, as you do more of them, you'll find that you learn more and you're going to want to talk about that stuff more and more. So it's a skill and you'll develop it over time depending on where you're at in your training. For neuromuscular ultrasound reports in muscles, you're going to list the muscle and the side image. And then you're going to give kind of a qualitative description of the muscle echogenicity or again, ecodensity. And if there's changes, you're going to talk about if they're homogeneous or heterogeneous. Again, if everything kind of looks the same or if things are patchy. If you're doing both sides, you can do thickness measurements. There's not great normative data on this, although there's some stuff that is kind of worked on. The problem with that is, you see patients all the time, and some people have bigger arms than other people. And well, what if you're doing teenagers and your kids? Like, what's a normal thickness? So I think if they're having unilateral symptoms, a side-to-side comparison is probably more helpful. Just like sometimes when you do your nerve conduction studies and you do a sensory response, you're like, well, that looks pretty normal. But then you go on the other side and you're like, oh boy, that's like, 3 times as big. All of a sudden, that normal value on the side you're studying becomes abnormal to you. So side-to-side comparison can be helpful, especially if you're seeing some abnormalities. So you've done your summary part, and now you're going to do your kind of conclusion and then the summary of your findings. So I always tell people, we'll say, does this look normal and does this look abnormal? I do the same thing with electrodiagnostic medicine. This is a normal study or this is an abnormal study. And then, you talk about your diagnosis or your description of the findings. Because a lot of times what you're doing in an ultrasound is describing some findings and what it most likely means. Sometimes you might see like a cyst or collection and you say this most likely is this, but I can't rule out like some kind of nerve sheath tumor or something. So just make sure you are not over diagnosing or being so certain of what it is that you're not saying, well, this kind of, I'm seeing this kind of cystic structure approaching it. It's most likely this, but I can't rule out these things. Kind of just, it's like when you get those radiology reports, right? You read them and it says, well, clinical correlation required. You get an MRI report and it says it's most likely microvascular, but then it lists, 5, 10 other things and says you have to kind of correlate clinically. You're going to be doing the same thing when you're doing ultrasound. And then, if you do it in conjunction with the EMG and nerve conduction study, you kind of talk about the correlation to the study. It confirmed my diagnosis of a carpal tunnel syndrome, and it looks like there's entrapment about the transverse carpal ligament. Or it confirmed that there's an ulnar neuropathy at the elbow. I was able to further localize it to here. Or we did this, and there's a cystic structure about the elbow that's compressing the nerve. You know, And then you're just like, well, do I have to include pictures in the neuromuscular ultrasound report? Like, if I'm doing this, do I have to somehow get an image into it? As with other imaging studies, CT, MRI, there's no need to incorporate images into the report. However, discussed prior, you do need to have the images saved somewhere. So if someone ever requested it, like let's say you did it for a surgeon, a hand surgeon, orthopedic surgeon, and they're like, I really like to see what you were talking about, or you mentioned there was a cyst and I kind of wanted to see what there was in preparation for my surgery. You should be able to provide those images to your practitioners if they ask for them, but they don't actually have to be on your report. It is nice sometimes if you include like a key image or something on there, but if your machine is a standalone machine and moving things is trouble, it is not needed formally for reports and billing. So it's nice if you can, but you do not have to do that. And that does not have to be there for you to bill. So let's talk about some billing codes. So now you've done your study, you've made your summary, and you're like, okay, what are the codes that I'm going to use? These are the most common codes that you're probably going to be using, okay? So there's the 76881, which what is it really? It's an ultrasound extremity, non-vascular, real-time with image documentation complete. So this code is if you say, I did a complete ultrasound on the elbow, and then you talk about the nerves about the elbow. You would also have to talk about the vascular structures at the elbow. You would talk about the bone structures at the elbow to use this code. So most times you're going to be using something like a 76882 code. This is the ultrasound extremity, non-vascular, real-time with image documentation, limited anatomic specific. So you can use this one if all you really do is talk about the nerve and how it looks and anything really close to the nerve. You don't have to talk about all of the other extrinsic structures. If you get good enough with this technology that you're talking about the bone cortical surfaces and the vascular and the other things going on, then by all means, you should build a 76881 because it's going to correlate more with how much work you did. And it is going to give you some more RVU and some more money. And there is a now newer code. It's actually been available for a couple years now, but it's the 76883. This is an ultrasound complete neuromuscular of nerves and accompanying structures throughout the neuroanatomical course with Rene real time with cine documentation. What does cine mean? It just means cinema. So most ultrasound machines, when you're kind of running them and then you're taking still pictures, they're usually running actually record, and you have the ability to record a video of what you're doing. So this code is used if you follow like the ulnar nerve from wrist all the way through the forearm, all the way through the elbow, all the way through the axilla, and you take pictures and video pictures all the way up through. So you can't use this code if you did ulnar nerve and you're like, well, I followed it through its course in the forearm and the elbow. If you just did forearm elbow, even wrist forearm elbow, you would bill a 76882 or a 76881, depending on how much other information you put in. However, if you did the whole thing and you even made a recording of kind of tracking video all the way up, then do the 76883. It's more work and it is more RVUs and the more billing. But you just want to kind of document it as you're doing such and then record the videos too and save the videos. Most, again, ultrasound machines, standalone or integrated, make it pretty easily to record the videos as well. Different ones have different kind of lengths, so depending on how long the video recording is, you might have a couple videos to track it all the way. Some of the standalone machines record for like a couple minutes, so it's easy to kind of take your time and go and then get a nice video of you tracking it through its whole course. It is important when you're using the code 76881 and 76882, and I'll show you when we do an example, but you're not going to say, I performed a limited ultrasound using a 6-15 megahertz linear transducer on the right ulnar nerve at the elbow. When you use 76881 and 76882, you're going to document as in the region or the area you did it. So you'll say, I performed a limited ultrasound using a 6-15 megahertz linear transducer on the left wrist, forearm, and elbow, or the left elbow, or the left arm. So when you're using those codes, you're using that kind of regional specific. Versus 76883, you will say, I performed a complete neuromuscular ultrasound of the left ulnar nerve, throwing it through its neuroanatomical course in the left upper extremity from the wrist all the way into the axilla. And I use still images and CNA images for analysis. And then you expound upon your findings. So a lot of times, if you're not doing this a lot and you're starting, you're going to use a lot. And I still use a lot of 76882 a lot of times. Someone comes in and I just want to know in this one region. I'm not going to do the whole thing just to do the whole thing. I'm going to do the test I need to answer the question to help my patient and provide maximal care. So you'll probably start with a lot of 76882 codes. There are other codes you can use as well, depending on what you're imaging. So some additional codes you might use is a 76604, which is a chest wall ultrasound. You're like, why do a chest wall ultrasound? Well, what if you're looking at the serratus anterior, latissimus dorsi, the rhomboids, the scapula? If you're doing kind of muscular ultrasound in that region about the chest, you would use that code. And you just have one chest wall. So you would just bill one even if you did both sides. Another code you'll probably use, depending on your expertise, is 76549. This is ultrasound with soft tissues of the neck. So for neuromuscular ultrasound, you would be using this if you're looking at the plexus and the associated structures, okay? Because you're going to start up in here, or maybe you're looking at the C5, C6, 7 nerve roots, and then you're looking at the trunks, and then you get some pictures of the divisions, etc. You would use the soft tissue of the neck ultrasound, and it's just one neck. So even if you do both sides, you just bill that one once. For the other codes for the limb, like if you did a 76882, let's say they came in for bilateral medium mononeuropathies and you imaged the left side wrist forearm and the right side wrist forearm, you would build two 76882 codes. Just in your summary, you would differentiate, I did the left and the right of these regions. So for the limb codes, it's per limb. For these kind of codes, it's a core, so it's just one, even if you look at both sides. Another code you'll run into is 76705. This is ultrasound of abdomen limited. And you're like, oh, geez, what am I doing with abdomen? This is the code that is used if you're doing diaphragm ultrasound. So if you're doing diaphragm ultrasound and you're either kind of looking up under the ribs, or a lot of times, more commonly, it's the intercostal view and the anterior mid-axillary line, and you're looking for diaphragm thickness, ecodensity, and then kind of thickening ratios, you'll use ultrasound of the abdomen limited. Again, it's just one abdomen, even if you do both sides. But that's the time you might run into using that code, because you're going to find a lot of papers and a lot of things on adding ultrasound to assessments for neuromuscular respiratory weakness. Or, you've all had that patient come in for kind of phrenic studies and you do them and it's really hard. And maybe because of the anatomy, your normative data usually for those amplitudes can, be as low as zero point 0.1 millivolts is normal, and you're like, man, I couldn't get it, but they kind of have a barrel chest and already have trouble breathing and maybe some other comorbidities. I don't know if my NR is because I just didn't get the recording technically or because there's a big problem. So adding ultrasound to see, well, does that diaphragm looks like it's the right thickness and functioning normal, um, can add some more information. So that's where you use that code. And then you can use codes like 76942 for ultrasound guidance and needle placement, okay? Again, when you're trying to get your 150 studies to add on, if you're trying to get that added qualification through the ABEM, you can't use the needle placement test. Now, if you did an ultrasound, again, like I said, if you said, well, I ultrasound the median nerve and I kind of found it as swollen there, and then I did the guidance for needle placement for treatment, or I did ultrasound guidance for needle placement, like I wanted to do a serratus anterior, but their chest wall looked atrophied, and I was a little nervous because I read those papers that that's one of the more higher risk muscles for pneumothorax, and I didn't know if I was really in the muscle or not. And you want to stick the ultrasound on and know your needle was in the muscle, you can use that code too. Um, at the same time, I just recommend documenting changes in the muscle, because then you can use the others. You could do the chest wall ultrasound code, and then if you need the needle, you can add the 76942 code for your needle placement as well. And then let's talk about some billing modifiers. So these are common modifiers that you're going to run into and using, because unless you're doing it as just standalone test, a lot of times this is kind of point of care addition, like I talked about. So this 2.5 modifier is going to be used if you're doing ultrasound on a patient that you did a visit code on. So let's say I saw somebody in the office and I'm talking to them, and we're going, and I know they're going to get EMG, but I'm just curious maybe about, do they just have carpal tunnel syndrome? Can I take a quick look? Or they're coming in for possible muscular dystrophy or myopathy, and I just want to take a quick look at the muscles. What you do is on your CPT code that you are, or your billing code that you're using for your visit, like let's say it's a new level 4 and it's 99204, you would add the 25 modifier and then bill your ultrasound code. So this just means, we've done an evaluation and management visit, and we've also done something else. And you put that 25 modifier in your visit code and then be able to build the ultrasound code. The flip side of that is, let's say you're in the EMG lab, you did EMG nerve conduction study, and you're like, I really think that ultrasound would add something to this patient's care. I want to do that as well. What you would do is you would build your EMG and your nerve conduction the same, however you do. But when you then build the ultrasound code, you would add a 59 modifier to it. This just means that you've done a separate kind of independent study on the same day. Because if you don't build the 59 modifier, then the insurance is probably going to only let you bill either the EMG nerve conduction study, the ultrasound, and you would want to build the EMG nerve conduction study. But you have the 59 modifier saying, I did this test, and then we did this other test too at the same day. So those are the two billing modifiers you'll use most. If your lab is hospital based and you have that like 26 modifier that you have to use depending on if you're separating out the technical and non-technical component, You can add like the 59 onto that if you have to. So it would be like dash 26 and dash 59 as well. That's fine. That's not an issue. So what I wanted to do now is just kind of go through some examples and kind of then some interesting cases. So this first example is a 28-year-old left-handed male, and he comes in because he's getting some numbness in the fourth and fifth digits of his left hand. You do nerve conduction studies, or your technologist performs your nerve conduction studies for you, and there's an absent left median sensory response to digit 5. And then the ulnar motor response showed slow conduction velocity across the elbow down to 38 meters per second. That's much slower than the A&EM recommendation, less than 43 meters per second. And let's say that's going to be well below the drop of 10 meters per second or more across the elbow. And there's even a 25% drop in amplitude across the elbow. So you have a partial conduction block. And then you do an EMG and you find chronic neurogenic findings in ulnar innervated muscles. So now already you can say, hey, I've already diagnosed that he has what appears to be a chronic left ulnar mononeuropathy at the elbow. Um, and then let's say his amplitude is spared. It depends on lab height, grade, severity, but maybe you'll say there wasn't any active denervation, but there was some pretty significant neuropraxia noted. And you could say, okay, am I done? And then the clinical neurophysiologist or electrodiagnostic technician and you says, well, is this going to be entrapped about the true cubital tunnel, between that fibrous bridge, between the heads of the flexocarpial ulnaris, or is this entrapped at the medial epicondyle, or something else going on? Did they have an injury? Could they have a bone spur? Should I do inching studies? I don't know how many of you like doing inching studies. I do not like doing inching studies. They're really tedious. It's a lot more shocks for the patient. But let's say you end here, you just say it's at the elbow, and let's say they are having some significant problem at work, they're a mechanic and they can't do stuff with their hand and they're going to get surgery, and then they go to their surgeon and he sees it's at the elbow. And then he says, okay, well, I just know it's at the elbow. So what am I going to do? I'm going to release it at the cubital tunnel. I'm going to do transposition. I'm going to clean everything out. And I'm going to do this big surgery because I didn't know exactly where it was or what else was going on. So I'm just going to have to open everything up and just move it over and do the whole big surgery. And then the clinician is, he says, well, did my patient really need that? What if it was just a cubital tunnel entrapment and they needed a release? What if it was not at the cubital tunnels, at the medial epicondyle, they just needed a transposition? What if something else was going on? And you're going to have to leave that to surgical exploration. Especially when it comes to entrapments, I think this is a great time to add ultrasound on. You know, you've already provided great information to your referring doctor, or even if it's your patient, it's you, as to what is going on with this nerve and what kind of problem is going on with this nerve and how bad it is, and probably where the problem is. The advantage of adding the ultrasound, though, is right now I can add on anatomical information that could be very helpful, especially if it's entrapment, especially if I'm thinking this patient might end up getting a surgery, or maybe they're just going to try to brace them for a while. So I have a little kind of video recording here of this patient, and then I'm going to kind of pause the video here. So what you're seeing here, this kind of ball of muscle, this is the flexocarpial ulnaris, okay? And then this is profundus musculature, and then this structure is the ulnar nerve, okay? And what we're going to do is we're going to track this proximally. And as we go proximally or further back up their arm, we're going to see where it traverses through the cubital tunnel, okay? So we're kind of following it backward from its normal track, and you can actually see it flip right up through the true cubital tunnel here. So it's going to flip up, and then here it is. So this ulnar nerve here looks pretty normal to me. If I go to the end here, this, you can already tell, well, that's like 3 times as big as it was before. Even if you're not sure exactly how big it is, well, then you can measure it. You can measure the cross-sectional area, and this cross-sectional area measurement, just, proximal here to that true cubital tunnel, is 22.9 millimeters squared. And most labs say, you get close to 9 millimeters squared and you're pretty abnormal. This is well above that. You're like 2.5 times the upper limit of normal. So already what you've done for this patient is you not only electrically localize it's at the elbow, But then with your ultrasound, you can say this is true cubital tunnel syndrome. And as probably many of you know, people who have true cubital tunnel syndrome where the entrapment is under that fibrous bridge tend to not get better with bracing. If people have it where it's at their medial epicondyle and it's more function, they're resting it on that or they're putting pressure on it and you kind of brace them, they can get better. And there's some nice papers that came out of Europe regarding this, but you know, and they described inching studies where they're like, if it was true cubital tunnel, they have to get that release. But if it's at the medial epicondyle, we would kind of have them wait. And they had kind of some more stringent electrodiagnostic criteria. So this is somebody that you would want to send for cubital tunnel release. Now, not only did you say it's at the elbow, but you've localized it further. And if they're going for surgery, your surgeon is going to be more confident, and then your patient can be more confident what's going on. Um, Here's an example of what maybe that report would kind of look like, okay? So I'd say a limited ultrasound with this machine using a 4 to 14 megahertz linear transducer was performed on the left forearm and elbow with the patient in the supine position with the elbow at 90 degrees of flexion. And I'd say the left ulnar nerve was identified and just proximal to the true cubital tunnel. And then I did some measurement afterwards, 2.5 centimeters distal to the medial epicondyle. It had relatively preserved ecodensity. However, there was significantly increased cross-sectional area of 22.9 millimeters squared, and a normal's less than 8.6. And then I provided some other, the ulnar nerve otherwise had normal ecodensity and cross-sectional area at the forearm, and I just kind of provided the values for at the forearm, the medial epicondyle, and proximal elbow. So, you know, for this patient, if I was going to bill it, it would be a 7682-59. And then I would also be billing for the nerve conduction study and the EMG, and I would just use those codes. But it adds those on. And then in the summary, what I do is I would have these two kind of first sentence lines kind of just right under the summary. So you have your summary of your nerve conduction and your needle findings. And then I would have neuromuscular ultrasound summary. I would have this blurb. Some people like to provide the values in a table format. It just depends on what your lab likes to use. We're kind of moving towards the table format just to get everybody kind of on the same page with the reporting, but it depends if it's you in a group or if it's just you practicing. And then, you know, I give the summary of the nerve conduction and the EMG like we talked about, but below that I would say, you know, neuromuscular ultrasound study, the left ulnar nerve is consistent with the entrapment about the true cubital tunnel, you know, fibrous bridge between the heads of the flexocarpal muscle. The nerve was otherwise normal at the forearm and elbow. And so you helped localize it further, and you probably helped this patient get the maximal intervention they need without getting more intervention they need. We've all seen those big, you know, and the surgeons are really good at what they do, but did they need the whole thing flayed open and moved and released and dissected? And then, you know, they could get scar tissue after that and things happen. So it just helps you be more precise with your patients. And if you really like to do inching, you could do that. I think it's a lot easier to just do an ultrasound and put the gel on and get the pictures. Also, I don't know about you, but when you do inching, you're doing your delta changes and you're trying to get it, and you're like, was I really on the nerve there? Is that really the best spot it's dropping? Um, you know, and you're thinking about where your stimming and the nerve is below. You can surmise ways in which things can be a little more off versus ultrasound is like this is the anatomy of what is there and what is going on. You might say, well, why didn't you just do an ultrasound in this case? You could have, and you could have said, you know, there's entrapment there. But then, you know, the nerve might be really big or have decreased echo density. That doesn't always correlate with the severity, although some of the changes in fascicular architecture probably do. I still think having the EMG and nerve conduction study is helpful. You know, if the distal amplitude is preserved and it's just mostly neuropraxia, time is on your side. If by the time they come in, they have atrophy and they're denervating diffusely, um, time is more of the essence. Like, hey, you know, consider, you know, this person is probably going to need surgery, but might also not have a complete recovery because there's already been some significant axon loss. The ultrasound isn't going to as easily give you that information. So I think it's more something you can add on. And that's why I like it being part of the EMG lab. You can add it on when you think it's going to help your patient and provide some more information regarding that. Here's another example. Let's say you had the same kind of patient, the same patient beforehand, but you're doing your ultrasound, and now this is an ultrasound image kind of at the medial epicondyle and the olecranon, okay? So this structure actually right here is the nerve, and then you kind of see this big ball next to it. So I'm going to go to my next image where I did kind of some measurements. So now I kind of outline more pretty for you. Well, here's the nerve, and the area of that nerve is borderline big for being at the medial epicondyle. But what's this? Squishing onto this nerve here, okay? You can do measurements and you could do kind of a longitudinal and get another measurement to real how big this structure is. But this is a relatively homogeneous cystic structure with this kind of brightness behind it is posterior acoustic enhancement. So this is like a pretty simple cystic structure that you're seeing here, okay? And then I'll tell you the history for this patient is actually that they had had some surgeries on their elbows after a motor vehicle accident like 10 years ago, and then slowly started getting numbness in their pinky and their middle finger. This patient already actually had a lot of denervation and axon loss too, and had a couple different surgeries at their elbow. I would even point out here that this bone has some abnormalities about its cortex and old injury, and maybe even some edema around there. But if you just did the nerve conduction study and ultrasound, and or if you just did the nerve conduction study and you got down and said it's the elbow, and even if you did inching, you'd be like, ooh, it really kind of looks like it's around the medial epicondyle. Maybe that patient does go and get a transposition done. This patient had a transposition, which must not have worked well because the nerve is not where it should be for a transposition, but maybe it migrated back and there was scar tissue. But that doesn't do anything about the cystic structure here. Okay. And for this patient, when you see this, this is really concerning for what's called an intraneural ganglion cyst. So probably what happened when this patient had their injury is you have an articular branch of your nerves that go to your joints, but sometimes you can have that synovial fluid that dissects along it, and then it will actually kind of get into the nerve and compress it from the inside. So as many transpositions as this patient wants to get, unless they decompress this, like they cut it, they drain it, and then they ligate that articular branch, it's not going to take the pressure off. And there's no way for me to differentiate that first patient from the second patient in a meaningful way without the ultrasound. Okay. And you might say, well, what about an MRI at the elbow? Could I see the cyst? And you might, but there's lots of papers, especially talking about your like superficial limb nerves and how currently with technology, ultrasound tends to have much better spatial kind of awareness and recognition than even MR neurography does. It's also way cheaper and easier. If I got an EMG nerve conduction study and they said, well, I could do an ultrasound right now and help your surgeon know what's going on, or you can wait a month to get an MRI that's going to be vastly more expensive than ultrasound. I say, well, get the ultrasound, just cool gel picture and it's easy. And maybe another thing would be, well, what if this person had a pin in their elbow? And MRI is also less useful. Ultrasound just to be able to get some good information. So I think this is just a nice example of how using the ultrasound can add quite a bit for your patient care and add something that you really can't know with the EMG nerve conduction study. Again, what I talk about with our fellows and residents is the EMG and nerve conduction study is like a really intense electrical examination of the functioning of these nerves, and it can give you clues based on where it is what you think anatomical problem is. The ultrasound adds on what is anatomically going on with your patient. So I think they just work really good as form and function together when you're caring for people. So let's move on to the muscle example. So your patient is a 55-year-old female who presents in the clinic for an evaluation of weakness. She had electrodiagnostic testing at an outside institution and it reported an irritable myopathy. It says irritable myopathy. Her CPK is elevated at 5,500 units per liter, and she's been referred because they think she needs a muscle biopsy, so she comes for neuromuscular consultation. On examination, she has rather diffuse weakness that is maximal proximally. So even your clinical examination with the CPK, you're not guessing that there's a myopathic process going on. But she has undergone 5 different lumbar spine surgeries throughout her life for a motor vehicle accident in her 20s. So already you're thinking about, your pathologist, and you're like, well, if they just go and take a vastus, depending on what myopathic problems going on, that might not be the best, but there's also likely going to be a lot of chronic neurogenic changes in those legs that are going to contaminate the pathologic change. So you're like, well, could I use ultrasound to help? And of course, the answer is yes. So, I grabbed the ultrasound machine and I was like, well, let me take a look at your arms. So this is an ultrasound of their right biceps brachii muscle. So here is actually the muscle here, and here's subcutaneous tissue, okay? For reference, here's a more normal appearing muscle, okay? The bright stuff for muscle is tendon, and dark stuff is actually the myofibers. Some people say this should look like a starry night or kind of a starry sky with, these kind of wisps of connective tissue throughout the musculature and then the normal muscle. And then here's this patient's muscle. So when muscle gets diseased, it gets brighter. So this is rather homogeneously hyperechoic kind of throughout the musculature. And again, depending on the strength grading, it would likely be a good muscle to biopsy because it has significant abnormalities here. Because the question was, do I really need to do another EMG? For muscle biopsy, it does depend a bit on your institution too, right? At ours, I do core needle muscle biopsies in the EMG lab. So we'll do the EMG, I'll do the ultrasound, and I'll do their biopsy right there. And then they can go home with a steri strip and a compression bandage. But if you don't have that capability and you're thinking open biopsy, we've all run into that situation where they had one biopsy and it was kind of borderline. It wasn't too helpful. Maybe on the EMG, you're like, oh, that, the vastus, one of the quads maybe isn't the best muscle to pick. So you want to make sure at this point, I think ultrasound is a good one to be like, oh no, my needle looked abnormal, the ecodensity looks abnormal, based on their strength, it's not end stage. This is a good muscle that's likely to give me good pathologic information for the patient. So again, here's just an example of normal muscle. And then for example, two, here would be my report, and this one would be pretty short. You could add a lot more muscles if you want to. We kind of have some scanning procedures that we do for myopathy amongst the practitioners. But let's say you just did it in the clinic really quick and you're like, I just wanted to look because I wanted to know if I wanted to have them have a biopsy of that muscle. And I'd say a limited ultrasound using a 4 to 14 megahertz linear transducer was performed on the right arm. Lateral imaging was obtained of the right biceps brachii muscle. And then I'd say there was significantly increased echogenicity in a diffuse or homogeneous pattern. See, this is an abnormal study. Findings consistent with a myopathic process affecting the right biceps brachii muscle. Based on imaging examination, biceps muscle biopsy would be a reasonable target for, muscle biopsy for pathologic assessment. And then this one, you would use that 76882 code if you wanted. Now, if you did ultrasound on like their arm and their forearm, and then you did some in their thigh and their leg too, you would then bill the arm and the leg for muscle. So you use 76882 times 2. And then I tend to kind of, what you can do is you can list the ultrasound and you say perform on the right arm, right forearm, right thigh, and right leg, and then provide all your summary. But when you bill it, you bill two codes. Now for this code too, you would use that 25 modifier on the visit. So let's say I spent quite a bit of time with the patient. It was like 60, 65 minutes between seeing them, charting, etc. And I do a 99205-25, and then I would just do the 76882, which would be different if they had EMG and I did it, because then you'd build EMG and you put a 59 modifier on the ultrasound. A lot of times what I recommend, if you do this just on your kind of like billing sheet for the EMG lab, just like have the code and then have the modifier kind of right on there, or just have I have like a little cheat table thing that I always use because I can't remember all these codes all the time between procedures and visits or televisits, etc. Okay, so now I'll kind of open it up, and good, I'm about at 50 minutes, so we can open up to the Q&A portion of this. I'm gonna
Thank you, Dr. Smith, for sharing your insights with us. Now we're going to transition into the Q&A session. If you haven't already, please share your questions in the Q&A box below. We have about 10 minutes to answer questions live, and we will try to get to as many questions as possible. If we are unable to get to any of your questions during the live session, please be aware that we will follow up with you after the webinar ends. And Dr. Smith, there are several questions already for you in the box.
Okay, how do I get to that Q&A thing? Oh, here it is. I found it. I found it. Yes, so 7.6. So the first one I see that says, this is from Kevin Dusenbury. I'm Smith, so I'm terrible with names. But it says are 76882 or 76883 nerve specific or limb specific? And like I said, it's limb specific. So when you're using those codes, you're not going to say, I did a limited ultrasound using this transducer on the left median nerve at the wrist and forearm. You're just going to say, I did it on the left wrist and the left forearm, or the bilateral wrist and bilateral forearm if you're doing two, and each limb counts on its own. So you have a 76882 for the right limb, right upper extremity, left upper extremity, right lower extremity, left lower extremity. Same thing for um, the kind of complete neuromuscular ultrasound where you're following it through. If you followed the ulnar and median through on this limb and the other limb, you would bill that one twice. It's those other codes that are just, for the truncal ones, you don't bill two. It's one trunk. But those are limb specific. Okay. So let's see for this next one. Can neuromuscular ultrasound replace the use of nerve conduction study in the assessment of the lateral, femoral lateral cutaneous nerve of the thigh? Um, yeah, if you're going to use a probe per nerve, I would have it be higher frequency. So when you're doing nerve ultrasound, at least 12 megahertz, if you can push it to more like 14, 16, even like 18 is really nice. A lot of times when you get to those, remember the higher you go on your frequency, the less depth you get. The lower you go in the frequency, the deeper you can see. So usually a muscle, I'll kind of drop it down to less than 10. I'll go to like 8 to 10. It just makes stuff a lot clearer. And then you change your focus. Focus changes are different on the newer machines. But for that, I'd use at least like a 14 to 16 megahertz linear transducer. And you can find the lateral femoral cutaneous nerve or the lateral cutaneous nerve of the thigh, depending on which, way you want to talk about it. It is small. Um, I don't know about replacing nerve conduction study because a lot of people, if they come in and even if, my thigh kind of burns and tingles and, you know, sometimes people come in and they clearly say, yeah, I do this, I wear my equipment, I wear my belt on that side, and during the day, then just the side. It doesn't go past my knee, it doesn't go up higher than my hip, and you're like poking and you're like, oh yeah, this is in the distribution of that nerve. Even clinically, I kind of know what you have. I would say the advantage of nerve conduction study in EMG is to rule out radiculopathy, plexopathy, and other things, because the nerve can, if you just do ultrasound, you won't rule those things out, which I think can be helpful to your patient. Um, but I do tend to, if they come in for that, and we all have that happen, right? You're looking at the patient, you're like, oh, you're high risk for this. Or maybe it's on both sides, and you're like, oh, I can't even do a comparison. You try to do the conductions, and you're like, I don't know if I got them or not. I think it's helpful in that situation, especially if you can find that ligament and you can see that it's kind of entrapped under that ligament. Okay, good question. Is the 59 modifier used regardless of whether a combination EMG ultrasound or two separate reports are generated? Yes. So if they had EMG nerve conduction study and ultrasound on the same day, you will use the 59 modifier. Um, Most of the time, again, the primary reason they're coming is the EMG nerve conduction study. I wouldn't say that if someone is ever just referred to the lab just for neuromuscular ultrasound, that I add in EMG and nerve conduction study, because usually in those cases, they already had an EMG maybe somewhere else that didn't have the ultrasound capabilities. But whether you do the report as a combination report, or even if you do them, say they separate, you will want to use the 59 modifier because two different procedures were performed by you on the same day. And you need to let the insurance company know that, or they're not gonna let you bill it. So whether the reports are separate, if it's on the same day, you have to use the 59. If they come a later day for ultrasound, that doesn't matter. It's another day, it's another procedure. So that's only if it's the same day. What should administrators understand about neuromuscular ultrasound? So they're not going to like it, if I'm honest, because, it is not a big money maker. And even if you look, that's why a lot of times, even in Pennsylvania, I haven't had trouble adding on the ultrasound billing because it's like $100 or sometimes even a little bit less than that. And these machines are expensive. So I don't go to admin saying, hey, I would really like to, like when I was trying to add it on to my office in Wexford, I didn't go and saying, hey, this is a big money maker. I said, no, this greatly improves patient care. And here's why. It helps me with surgical localization. It'll make my surgeons more confident. It adds more information for the patients here so they don't have to come down to the main Presbyterian lab. So you kind of show its utility in improving patient care and accessibility. If you go just on money, it's going to take like 4 to 5 years to make the money back for the machine. And by that time, as you know, with machines, you're like, ooh, it depends on how good the machine is, how long it's going to last. So don't go to administration being like, this is going to be a good big money maker, but be like, hey, we're going to be the experts in this. This is going to help our surgeons. This is going to improve patient outcomes. This is going to help find diagnoses that we wouldn't find further. Another thing that's going to happen is outside of physicians performing this, there's going to be more people like physical therapists, or depending on your state, we have physical therapists that have their own boards for nerve conduction study and EMG. And if physicians aren't getting on board and getting training and using this technology, someone else is, and it might not be the best person to do that test. So I think that's the best way to navigate that. And there's some really good papers on like carpal tunnel syndrome and elbows and kind of the more common things that labs tend to see that show that ultrasound adds a lot. I would go that route if you're trying to get it. If you try to do the physical one, it's going to be tough. So talk about patient care and improving workflow and improving surgical localization. That's the way to do it in my mind. So if you do median and ulnar nerve on the same limb, it's just the same code. You don't bill, like if there's that comprehensive nerve one, like if I track the median and the ulnar nerve all the way through, or just the median or just the ulnar nerve, it's limb specific, so it's just one. Or if I do a limited ultrasound, and let's say I do look at the person has a carpal tunnel syndrome and an elbow, because they have like a generalized, diabetic neuropathy and they get entrapments easier, and they also have these entrapments. And you do the median at the wrist and forearm, and then you do the ulnar at the wrist, forearm, and elbow. It's just the one code per limb. So it's limb specific. So even if you do multiple nerves, it's just one limb. Usually what I tell people, well, if you're gonna like look at those two and you're gonna be all around here, I would just track the median and the ulnar all the way through and then use the comprehensive neuromuscular ultrasound code, rather than doing a limited assessment on two spots. It depends on your workflow, but that's just what I would recommend. Yes, if you use and the next question, if you use like, if you're like, ooh, this is a scary muscle, this is like a serratus anterior, or it's a rhomboid, and I'm not sure if I'm in the lower trap or if I'm really in the rhomboid, um, or maybe you're worried about doing a sternocleidomastoid, they made a really thick neck, and you're like, ooh, I'm a little nervous, I'm poking around in there, there's some fun structures there you wouldn't want to hit. That code, that needle guidance code, can be for positioning for EMG. So it can just guide the needle. Um, you can use that code too. And then if you also did ultrasound and you commented on some of the neck structures or some of the trunks or the ecotexture of the neck, I would use the neck code. And then I would say, I did use 76942 to guide, and I'd use both codes. That's a good one. How much time do you allocate for carpal tunnel syndrome bilateral or cubotunnel bilateral? Um, I guess, could I ask a question of Kevin Colburn? Are you talking about just ultrasound? Or are you talking about if they had EMG nerve conduction study and ultrasound? I don't know if you're still on, but if you could just type so I know. Ultrasound. So there is a different code for ultrasound guided injections. Um, but yes, so let me go back. So let's say that it's just the ultrasound. The ultrasound takes me like, I don't know, 5, 10 minutes a limb, because usually what I'll do is I'll get all the pictures that I'm happy with, and then I'll let the patient go, clean the machine off, or the tech clean the machine, and then I'll do my measurements. Um, I don't think it adds too much, but it depends on how your lab's set up. I've worked at a lab where it was me and one tech, and it was like each patient had 40 minutes, and we had two rooms and two machines. So a patient would come in, tech would have 40 minutes to conduct. Then they would basically go grab the next patient, start the next one, and I would do the needle. And then we'd like be going back and forth, kind of staggered. At our current lab, we kind of do like 4 studies in the morning and 4 studies at the afternoon, and they're staggered in a funny way. Um, I don't have, I think you know, 5, 10 minutes for each limb. If you start doing them, when you start doing them, I think a good place to start is the median nerve at the wrist because it takes some time to getting used to. But once you kind of get good on it, it's just they're in position, the gel's on, there it is, picture, there it is, picture. Um, it's less tedious, you're just the gel and you're kind of going boom, 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 and you'll get better at it. But I don't think it takes that much extra time unless you're already like really tight on your time in the lab. And even in that lab, I went back and forth. We had an ultrasound machine. I'd grab it, I'd do it, and I'd say go, and I'd just do the measurements a little bit later when I'm sitting down and maybe typing the EMG part of the test. 59 modifiers for 2 procedures in addition to the E&M consult code. Yes, yes. So just like if you do an E&M consult and you bill that and then you do the EMG nerve conduction, your E&M consult already usually has a 25 modifier. Then you do EMG nerve conduction study, then you do ultrasound. The ultrasound will still have the 59 modifier. If you just did E&M consult and just EMG, your EM consult would have the 25 modifier and you just have the EMG codes. If you just did consult and ultrasound, you would just use the 25 modifier on your consult code and then your ultrasound code. If you do consult, EMG nerve conduction study, the consult already has a 25 modifier, and then you do ultrasound, you will still put the 59 modifier in. That just means you've done multiple separate procedures on the same day. So you're not saying that the ultrasound is also the EMG nerve. It's use a separate machine, you use separate expertise. So you would do that. That's correct. And then the exact code, I have to look it up. Cadwell actually has a really nice list of the codes, but they have one specifically for like injection. Um, can you use, yeah, like we talked, that needle guidance, you can use that if even if you're doing a limb, like let's say you haven't done a flexor pollicis longest in a long time, and you're like, oh, I really am not sure if I'm in that muscle. You can use that code as well for guidance for limb muscles. It's just, did I use the ultrasound to put the needle there? Did I use it for the diaphragm? Did I use it for this? I don't use that code a lot, but it just depends on your practice. Sometimes if they have a lot of atrophy and I'm like, am I really in that muscle? Is that muscle even there? Sometimes you actually do the ultrasound and you see that there's like no serratus anterior. So you're like, if I poked a muscle, I'd probably post an intercostal. You might have said it looked normal. Um, if your patient is referred to regular bill, at our lab, we don't. We don't usually bill for the consult. I still do a very kind of brief history and examination, but there's caveats. We have people that are sent at times, for both. You know, let's say get a referral and they're coming from 3, 4 hours away and it's for motor neuron disease. And I'm like, I'm probably going to want an EMG no matter what at our lab. Why not just see in the EMG lab for consult time and the whole thing? But if people come in for numb hand referral from the family doctor and it's carpal tunnel, even though I do a brief history and physical, usually, honestly, our lab doesn't bill for it. Um, so it depends on the complexity. I'm more likely to do it if I'm going to be doing needle muscle biopsy, or again, if they're sent for motor neuron disease, or I start examining them and I'm like, this is going to be complicated. And I had a patient on Thursday who had a couple EMGs and then came in and they got diagnosed with maybe motor neuron disease, but it was clear they had probably had type 2 myotonic dystrophy. So I ended up doing a consult because I ordered genetic testing on the patient. I wanted to establish care so I could do that. But we don't routinely do it for those entrapments. Just again, it depends on your lab. You can. You just want to have the documentation to back it up.
Thank you, Dr. Smith, for leading today's session. We appreciate your insights on neuromuscular ultrasound diagnostic and billing perspectives. I also want to thank everyone who joined today's session. We appreciate you sharing your time with us. As a reminder, please look forward to an email from Cadwell Education with a link to the post-webinar survey. If you have any questions about today's session, or you are interested in scheduling a demo with your dedicated representative, please reach out to marketing@cadwell.com. Have a wonderful day, and thank you everyone for being here. Thank you,
Thanks
Dr.
for
Smith.
having me. Thank you, everybody. I hope you have a good day.
Thank you.
Bye.